So this is Molly Henderson. This is an extern 4-week-old neonate post-op day 1 from Tetra Pair. Our operative course had no complications. Our post-op echo had showed good biventricular function. Our goals are to maintain hemodynamic stability and ensure adequate cardiac output. We are watching for post-op concerns of low cardiac output syndrome, arrhythmias like jet, right ventricular failure, and bleeding.
Great, let's go through the CAP bundle. Do we have everybody here? We have the bedside nurse.
Yep, I'm the bedside nurse.
And the charge nurse.
Yep, I'm here.
We have the RT.
Here.
Cardiology attending.
I'm there.
ICU attending.
I'm here.
I'm the APP, and we have the cardiologist, or the ICU fellow. All right, Laura, do you mind filling out the sheet?
Yep, I have it right here. I'm ready to go.
Great.
Okay, so let's run through some of the anticipated concerns that you mentioned that might result in the patient decompensation. The one I'm most concerned about right now would just be low cardiac output syndrome. So Hillary, do you have any ideas of what we'd be watching for?
I think I would see some tachycardia and hypotension along with decreased MAPs, decreased NERs, and increased lactates.
Great, let's go over some vital sign decompensations that we might see with the low cardiac output and go over the mitigation plan.
Great. So for tachycardia over 200, go ahead and call any provider. For any tachycardia, we'll have a bedside discussion. If the heart rate is high, along with low MAPs, low CVP, and low urine output, go ahead and draw up a 5 ml per kilo bolus, and you can start giving that before we get to the bedside.
So at what point would you be comfortable with us giving some dwindle epi before you're at the bedside?
Yeah, that's a really good question. I think if the MAPs were falling below 30, we wouldn't want to wait for a provider to get here. So you're empowered to give the dwindle epi at that time and wait for us to arrive.
Okay, so if MAPs are below 30, then we will give dwindle epi and then I will go call the providers.
And how about arrhythmias? What might I see and how are we going to mitigate those?
Yeah, so if we see signs of jet, so neurocomplex QRS with no P wave, rhythm with multiple ectopic foci with loss of AV synchrony, and we're going to go ahead and get our pacer wires out and connect them to the pacer. And we'll start pacing for heart rates less than 180. Also, we'll work on the environmental cooling, some decreasing catecholamines, as well as providing our provider team with an update as to what's going on.
Okay, I think that sounds like a good plan. I'm putting that on this sheet. We also need to identify what our goal vital sign ranges are, if you want to go over those.
So my goal heart rates for this patient are from 140 to 175. My goal MAPs are above 38. SATs above 90%. CVP goals from 11 to 16 for the trends that we've been seeing before. And NERs trending above 50 as they have been post-op.
And then from a lab standpoint, we'll aim for a lactate less than 2 and an SVO2 of greater than 50. Sound good? Okay, let's wrap up by going over our preventative measures, our bedside medications, equipment, and the patient's status.
Our preventative measures include pre-sedating for all things stimulating like suctioning and cares, no baths or weights, no IPV. All our drip changes will be high risk and we'll have an additional person at bedside.
Great. So our meds at bedside include a cardiac code pack that has dwindle epi, code-dose epi, and calcium chloride. We also have sodium bicarb, 2 MEQs per kilo at bedside, as well as rock, morphine, and an LR fluid bolus if we need it. I also have my pacer, my ediometry is on, and my NERs are also on.
And I'll make sure the nurse is pre-sedated before suction.
Okay, I think we have a good plan. I do think it's important on all patients to clarify that she is an ECMO candidate. Since it's so close to surgery, it would be a central cannulation, so we don't have to worry about ultrasound mapping right now. It would also be an ECPR candidate. So if we're in a code situation, anyone's empowered to activate ECMO without waiting for the attending to do that. Okay, so I also need to mark on here what our overall trajectory is. Just being post-op day 1, not really seeing a lot of clinical improvement yet. I'm just going to mark same. Is everyone in agreement with that?
Yes.
Great.
Okay. So we've gone over most things on here. Are there any questions or concerns that we need to address?
I think we have a good plan.
Okay. So just to verify that we've gone through this conversation, I'm going to sign the form and then Hillary asked you to do that as well. And then when I'm leaving the room, I'll fill out the post-huddle survey on the QR code.
Okay. So to make sure everyone in the unit knows that this patient's on the CAP bundle, we have this head of bed sign that we'll put up here so people know when they walk in the room. And then the bundle will be near the code sheet as well.